Hello everyone, my name is Pablo Leite. I'm an oral and maxillofacial surgeon. I work in a private practice in Rio do Sul and Blumenau City. I'd like to say thank you so much to Dr. Pistorello for the invitation to share his presentation, his lecture with me. And I'm going to talk about some surgical details about that case of surgery first with a maxillary segmentation and a counterclockwise advancement using aligners. And my protocol, the diagnostic protocol in the analysis of the dentofacial deformity, I took in consideration facial clinical analysis with the patient in repose, rest, and smile. And I use some geometric methods to analyze the images to get important information about the diagnosis of the dentofacial deformity. And here you go, clinical examination. In this clinical examination, you can observe the extraoral and intraoral view of the patient. In the intraoral view, it's a dual occlusal plane and open bite about 4 millimeters is clear. In the extraoral examination, you can observe the class 2 facial profile. You can observe the upper dental midline deviation to the left and no too much tooth exposure during smile, no gingival exposure, and asymmetric mandibular with deviation to the left. And point that I consider really relevant in this diagnosis is the operating room position. What I want to mean with this, I want to describe, or I want to mean that in the operating room you don't have the muscular tonus over the jaws. Then you need to know as much as possible, or need to have as much as possible in the diagnostic CT seated condyle position. Then you have a more precise possible diagnosis, as I can get here with an wax bite that your patient use to get the CT. As you get CT, as you confirm the condyle is seated, you go to the three-dimensional head orientation with Nemafab. I consider a great software for do this. And in this three-dimensional head orientation, I use some clinical finds that I consider relevant for this orientation. After this correct orientation, after this to correct get the planes of the skew, I can have a mid-sagittal plane obtained from the CT, and over this mid-sagittal plane obtained from the CT, I start my soft tissue cephalometric analysis from Dr. Arnett, published in 1999. And from this, I can get some significant, meaningful information of this patient, mainly because it's a surgery first case, when you need to know some details about the upper incisor and lower incisor inclination, and you can get some important diagnostic information about the position of the soft tissues point B and soft tissue point Pagano. And you proceed with some sagittal analysis, and you trace a sagittal advancement, and you can get as much as possible precision in this movement, the sagittal movement of the jaws. And you can have here the numbers that I got after this projection. Now, as I know the sagittal measurements, or the best sagittal position you could get, I go through 3D cephalometry when I put all the points, all the geometric points over the meshes obtained from the CT. And following some positions in this order, I start by frontal, then sagittal, then axial, and I can start the 3D manipulation of these meshes for a 3D cephalometry point of view to get the better 3D environmental surgical planning. In the frontal view, you can observe here the correction of the upper dental midline and some correction of the maxillary, which as our head orientation showed it's necessary. In frontal view yet, you can observe the correction of the mandibular rotation in the frontal plane, and that correction was got by differential movement in the vertical way, with the left molar going up and the right molar going down. In the sagittal view, you can observe the maxillar incisor advancement is 4.5 millimeters. A degree of occlusal plane change is about 12 degrees of occlusal plane change, and a huge pogonial advancement, 12 millimeters. As you can observe at the mesh, you can get these movements for the planet sagittal in the 2D environment. Added to this sagittal movement, I would like to mention here the maxillar segmentation that was carried out between canines and premolars because of the skeletal anatomic aspects of that open bite, is a skeletal open bite, and because as I did the procedure between the canines and premolars, I could get ideal final occlusion. In an individual analysis of this maxillary segmentation, I can observe the movement, for example, the movement of the anterior segment and go forward with a little intrusion. Is you can observe this movement in an anterior-posterior and an axial view. And the posterior component, in the posterior component of this maxillary segmentation, you can observe the differential rotation of the segments that contribute a lot for the symmetry achieved at the jaws. As you can see here, the left molar go up 0.96 millimeters, and the right molar goes down 0.21 millimeters. This posterior component added had some rotational movement. The first right molar go 2.31 millimeters to the right, the left molar 0.1 millimeters to the right. This rotational component help a lot for the facial symmetry that you get. And here you go, you have the counterclockwise mandibular advancement to get the final occlusion. Take a look at the movement of the pogonium, the movement of the mandible. All this movement was mainly obtained by closing the open bite. With the closing of the open bite, with the counterclockwise advancement, you got a pogonium-Martin advancement. And finally, the last surgical movement in the axial view, you can observe some differential rotational movements of the molars. With the left molar go forward 5.46 millimeters and the right molar 4.48 millimeters. This contribute to correct little axial deviation in the mandible. Thank you so much.